Picture this. You walk into your patient's room, and as they reach out to greet you, their hands just start uncontrollably flapping. You lean in to check on them, and right away you catch this distinct, sweet, kind of musty odor on their breath. Well, these aren't just random weird symptoms. No, this is the visceral, scary reality of a failing liver that is quite literally poisoning the brain. Welcome to today's Explainer, guys. Today we are absolutely mastering hepatic encephalopathy for the NCLEX. Honestly, this is one of the highest yield med-surg topics you are going to see, and by the end of this, you'll know exactly how to recognize it, manage it, and completely crush those tricky board questions. Okay, let's just dive right in. At its core, hepatic encephalopathy is a neuropsychiatric syndrome caused by liver failure. But to really make it stick, I want you to visualize it like this. Imagine a thick, toxic fog just rolling in over the mind. That fog, that's ammonia. Normally, your gut breaks down protein and produces ammonia as a byproduct, right? But when the liver fails, it can't clear that ammonia out of the blood anymore. So instead, that toxic compound just builds up, crosses the blood-brain barrier, and totally blankets the brain in this fog, causing an altered mental status. And that can range from really subtle, mild confusion all the way to a deep, unarousable coma. So, let's talk about the pathophysiology. How exactly does this fog roll in? It's basically a massive domino effect. Step 1, the liver fails. Now, a healthy liver acts like a chemical processing plant. It takes toxic ammonia and converts it into completely harmless urea so we can just pee it out. But a damaged liver, it just can't pull that off. Which brings us to step 2, ammonia rises. Our gut bacteria and the proteins we eat, they keep making ammonia, but there is zero clearance happening. So, step 3, all that ammonia builds up in the bloodstream and sneaks right across the blood-brain barrier. Step 4, brain dysfunction hits hard. This neurotoxicity causes the confusion, the personality changes, and those weird motor issues we talked about. And finally, step 5, if we don't step in and intervene, this cascades into stupor and eventually a fatal coma. Moving on to recognizing the signs and symptoms. The absolute crucial point here for us as nurses is recognizing how this progresses. Early on, you might just notice some subtle confusion. Poor concentration, maybe they're acting a little out of character. Actually, a classic early sign is sleep pattern reversal. They're wide awake all night, completely lethargic all day. But as that toxic fog really thickens up, we start seeing the major red flags, like fetor hepaticus. Remember that sweet, musty breath we mentioned earlier? That's exactly what that is. And if it goes unchecked, we're looking at severe disorientation, stupor, and eventually coma. But nestled right in the middle of this list is our absolute biggest warning sign. Asterixis. Seriously, burn this word into your brain. Asterixis is a flapping tremor of the hands. If you ask a patient to hold their arms straight out in front of them and extend their wrists back, kind of like they're telling you to stop, their hands will involuntarily flap downward and bounce back up. Asterixis equals flapping. This is the hallmark motor sign of hepatic encephalopathy, and frankly, a massive high-yield memory hook for your exams. If you're reading a question and it mentions a flapping tremor, your brain should immediately scream, ammonia toxicity. All right, next up, we need to talk about finding the hidden triggers or precipitants. Because this doesn't just happen out of nowhere. As a nurse, you need to be actively hunting for what pushed them over the edge. Things like an infection, constipation, dehydration, these all stress the body and can easily trigger an episode. Also, watch out for sedatives and benzodiazepines. They actively worsen encephalopathy by further depressing the central nervous system, so whatever you do, do not give them. But the absolute biggest culprit, and this is a huge one to remember, is GI bleeding. Why? Well, blood is absolutely packed with protein. If a patient is bleeding into their gut, that blood acts like a massive protein load. The gut bacteria just feast on it, break it down, and produce a giant spike in ammonia. A GI bleed is an absolute emergency for these patients. So, what do we actually do about it? Let's look at priority nursing interventions. Here is your ranked list of priority actions. Number 1, always protect the airway and ensure safety. Think about it. If a patient is obtunded or slipping into a coma from ammonia toxicity, they lose their gag reflex. That makes them a massive aspiration risk. Number 2 is our primary medical weapon. Administer lactulose. Number 3, you've got to identify and treat that precipitating trigger. Stop the GI bleed, treat the infection, whatever it is. 4, we can add a medication called rifaximin. It's an antibiotic that actually reduces the ammonia-producing bacteria in the gut. And 5, nutrition. We need to give them adequate calories, but with moderate protein to prevent malnutrition without overloading their system. Now, I want to pause for a second and zoom in on intervention number 2, lactulose, because honestly, this is where a ton of nursing students get tripped up on test day. Lactulose works by acidifying the gut, basically trapping the ammonia and then pulling it out of the body through the bowel. But how do we know it's actually working? Well, we titrate the dose specifically to achieve 2 to 3 soft stools per day. That is the magic number. And here is your ultimate NCLEX trap. Remember this memory trick: lactulose, because the goal is loose, soft stools. If the patient develops diarrhea, do not stop the medication. Seriously, don't do it. That frequent stooling is exactly how the toxic ammonia is leaving their body. If you hold the lactulose because you're worried about the diarrhea, that ammonia is going to spike right back up into the brain. So instead of stopping the drug, the correct nursing action is to monitor their fluid status and watch for hypokalemia or low potassium, since they're losing all those fluids. All right, time for some baked-in NCLEX moments. Let's test your knowledge. Get ready to drop your answers in the comments. Question 1. Which assessment finding is most characteristic of hepatic encephalopathy? Is it A, bounding pulses, B, Kussmaul respirations, C, Asterixis, or D, a positive Chvostek sign? You've got 3 seconds. Drop your answer below. 3, 2, 1. Okay, if you chose C, Asterixis, you absolutely nailed it. Remember, Asterixis is that classic flapping tremor of the hands when the wrists are extended. It is literally the signature neurologic motor sign that ammonia toxicity is actively blanketing the patient's brain in that toxic fog. Let's try one more, just to really lock in those hidden triggers. Question 2. A client with hepatic encephalopathy has worsening confusion. Which factor could have precipitated this? A, a low-protein snack, B, a gastrointestinal bleed, C, daily lactulose use, or D, adequate hydration? 3, 2, 1. The correct answer is B, a gastrointestinal bleed. Remember what we talked about earlier? Blood in the GI tract acts as a massive protein load. When those gut bacteria break down that blood, it creates a huge surge of ammonia, which the failing liver obviously can't clear, directly worsening the encephalopathy. Things like lactulose and hydration, those would actually help the condition, not precipitate it. You guys did fantastic today. I want you to remember this final hook as we wrap up. Ammonia up equals brain confused. But consider this: if a patient with a GI bleed suddenly stops flapping their hands, are they getting better, or are they losing all motor function and slipping into a terminal coma? Keep questioning, keep studying. If this explainer made it click for you, make sure to subscribe. We're dropping one killer med-surg topic every single day until you pass the NCLEX. I will see you in the next one.